This episode is brought to you by podiatrygrowth.com/podpatrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5-email introductory course. That sounds expensive. What are we paying for that? $1,000? $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol.
Podiatrygrowth.com. Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters.
All right, welcome back to Pod Patrol with your host, Dr. Jeff Dikis. Tonight I'm joined by Dr. Jordan Sisto. Thanks for joining me tonight.
Absolutely. Thank you for having me.
Yeah, absolutely. I'm excited about this episode. So you and I kind of started crossing paths online, which is a common theme these days. You know, you have your kind of in real life friends from residency or conferences or whatever. But with the advent of social media, the people that put themselves out there, put their cases out there, you start to feel like you get to know these people. But this is the first time you and I have actually talked. So it's kind of interesting how that works.
No, absolutely. Yeah, ever since, LinkedIn, it's definitely one of those things where in the beginning it becomes a little terrifying, but then you put your cases, that's the thing with me with LinkedIn is that you continue to learn every single case you post, and I love it. So it's helped my practice actually and how I actually address these ankle fractures too.
It's a really interesting component of medicine. We'll jump into that in just a second, but just a little backstory. You went to Shoal and then Legacy out in Portland, hung out with my buddy Drew Schinnebarger out there, one of the faculty, and then you did fellowship at University of Louisville. We were talking before we started if it's Louisville or Louisville. I was saying that my whole life it was a Louisville Slugger. But then when you actually go there, they say, no, it's Louisville.
Yeah.
They probably taught you how to say it correctly after you went there.
Day one.
Yep. Step one, learn how to say Louisville. And now you're out in Mesa, Arizona. So you took up the warm weather. So how is it out there in Mesa, Arizona?
No, it's beautiful. Obviously you can't complain about the weather. I think the patient population's a little bit different than a lot of other places because we have so much. We call them snowbirds. They're starting to come out and flock to the valley right now. So we're starting to see a lot of these low energy geriatric type trauma cases, but it's fun. I love it. I mean, there's something you can do every day. The weather, you really can't complain or beat.
So what is the model that you're in? What kind of group are you in?
It's multi-specialty. I mean, but for our group, at least here in Arizona, it's private practice. So we have, 6 podiatrists here. We have an office here in Mesa, and an office in Glendale, Arizona, which is just kind of in the west, in the West Valley. So,
what was it that drew you to fellowship? I have a lot of younger listeners who are interested in fellowships, and I think fellowships have been gaining interest more recently as the number has grown, the interest has grown. So, what drew you specifically to seeking out fellowship?
That's an excellent question. I think the big part, especially, there's a lot of programs where where you went like UPMC and where I went in Legacy, the exposure is very broad. So you feel like you can tackle anything. And I felt that way after residency for sure. But with me, at least in the Pacific Northwest, there's one way to do certain things, and that's what you learn all throughout the 3 years. And it's a phenomenal way. Patients, outcomes, and everything was excellent. But I kind of wanted to venture out and kind of see how else can we treat certain fractures? How else can we treat certain deformities? And I was actually shocked by how different things were actually done in a different area of the country, you
Mhm.
know, and so it allowed me to take off the blinders a little bit and kind of see, okay, there actually are different ways to address a certain situation. And so it allowed me to kind of see a different philosophy.
Yeah, I don't think anyone would ever argue that more training or more knowledge or learning from multiple people is a bad thing, right? And
Mhm.
so whether that's geographical or, you may even learn from different people that are in the same city, different techniques or so. But definitely there are geographic biases that are out there in terms of how people fixate things. Certain companies seem to be like medical device companies seem to be more popular in certain areas for whatever reason that may be. But learning different strategies, techniques, ways to approach things, and then learning how to use different devices, whether it be different intermedullary nailing systems or different plating systems, or not every staple is created equal. So getting that extra training, I think, is very reasonable. How did you go about starting the fellowship search process? I think people will be interested to know that.
Yeah, I kind of knew you kind of want to plan ahead. I mean, I think I was in the beginning or middle of my second year of residency where I'm like, you know what? I have a pretty good idea of, the training I'm going to get, and it was excellent. But I just kind of knew, I want to continue to be comfortable being uncomfortable. And I think by changing geographic regions, learning new techniques, I wanted to continue that after graduation, and that's what I did. So I started just kind of doing cold calls or emails to directors and even staff, or even trying to get in tune with residents at the program. Then people email you, people will call you, text you. Podiatry is so small,
Hmm.
right? A tight knit community where it's pretty easy to communicate and get information or insight. And so it was in my second year, then third years when we started interviewing.
How did you narrow down the fellowships? Because there are a lot of them. How did you start to figure out which ones might offer you something that you would actually be interested in going to?
I think it was just the interview process, and I think the first was just the interaction with the director. The one in Louisville, I don't know, we just hit it off. A lot of it wasn't even academic. I mean, you come from an academic or a good program. I think they already know based on your numbers. You obviously you can do surgery. You have good training. How are you as a person? And yeah, we just got along. We hit it off, and I just like their philosophy. And their fellowship program is essentially 6 months trauma service and 6 months sports medicine. And so I just kind of wanted the trauma aspect of it, because I knew that they work so closely with orthopedic surgery residents. You kind of do everything. You get exposed to everything. You're training
Hmm.
not only the residents at the program, but also you're with another fellow, but you're also with all the orthopedic surgery residents. So you just become this one group, and you see and do so much. And so I think for the first, how I kind of delineated where I wanted to go, and what geographic region I wanted to be at, was just the first interaction with the director himself.
Yeah, that makes sense. Because I have students who rotate through with me, and there are certain students who I would let spend the whole year with me. And there are students where after a week, I'm like, all right, how much of this month do we have left? I'm ready to move on. And so I can't imagine spending a full year with someone that you felt that way about. So I can fully appreciate and understand that at that point, if you meet the low bar of, not low bar, but if you meet a certain standard of competency, at that point, it's just, are we going to get along? Are we going to mesh? Are we going to have a fun time? Because residency is fun, but fellowship can also be fun, right? Hanging
Mm,
out, doing cases, spending time together. It is a bond that you form, a year-long bond with these people. So choosing the people that you're going to get along with and enjoy getting along with, I can imagine from, if I was a fellowship director, I think that would be a big part of what I'd be looking for. Again, once they've met this kind of minimum
yeah,
competency that I'm looking for.
100%.
So what made you think, let me back up. takes a lot of balls to start putting cases on LinkedIn because you have to have some amount of confidence. I put a lot of cases out on LinkedIn. And the interesting part about LinkedIn, I find, is that the cases where everything is perfect, you get no comments. Like nobody responds. Nobody's like, great job, doctor. Wonderful. You nailed that one. There is no positivity. But if they don't like one little thing, I wouldn't have used that screw. That screw's too long. What about, why are you using that plate? You shouldn't use that plate. What about this? Then you get 200 comments of people who want to give you their opinion and tell you why what you're doing is not the way that they do it. That being said, setting the stage with that, what made you want to start putting your cases out there into the world of LinkedIn, the sharks of LinkedIn?
Yeah, honestly, for me, I just wanted to, I think it was a pathway for me to learn more, right? Because I'm not working every day with residents and fellows as much as I would like to. Every now and then we have residents from the VA and another hospital system out here, but it was a way for me to continue to learn. And I knew there's gonna be some scrutiny, there's gonna be some criticism, but I love it. I feel like that's a way for one, it's a way to learn, right? And yeah, you gotta have thick skin, but I appreciate the comments because that's ultimately going to possibly alter how I do something in the future. And so it's a way just to, I think, humble yourself, but also improve your techniques and the way you learn moving forward, so you're never in this place of complacency.
Yeah, and you can kind of take it one of two directions. You can be humble like you are, or you can get defensive like I do, because I can't possibly be wrong. The way I do it is the correct way to do it, and anyone who says anything different is crazy. And let me teach you why the way I do it is correct. Obviously, I'm joking. I pick up a lot of things. I learn a lot of things on LinkedIn from people that, throw things out there. They post their own cases or whatever. But it depends on the person. I now know who the kind and constructive people that comment, and I can predict if I see their name pop up on one of my posts, you get the little notification on your phone, such and such has commented in your post, like, this is going to be, I know exactly what this is going to be. This is going to be something negative. And I call people out on it sometimes. I don't think they're prepared for that. And I will write back and I will be like, you're being rude. And I don't know if you're meaning to be rude, but my wife yells at me because I'm getting these LinkedIn battles. Like, what's going on? But yeah, it's a wild, wild west out there, man. But I do agree there is a lot of benefit out there of sharing cases, and the people who are constructive providing some feedback on cases that most of the time, the vast majority of the time, like I said, is constructive and does give you a little bit of confidence to say, like, yeah, I am doing this appropriately, or I am tackling this the right way. Or if you have a novel idea or a novel technique, that feedback to say, wow, yeah, that's a really great way to do that. I'm going to start adopting that. And you're like, oh, okay, cool. That's nice feedback to hear. So it's a crazy place over there in LinkedIn.
It is. It really is. I never thought, there you have all these, I think, other benefits too that I really never went in knowing, getting your cases out there and getting good results and making new friends, but also potentially getting the interest of certain orthopedic companies too to help them out too. So you have all these other secondary benefits that I never realized, and it was never a motive or a goal of mine. My goal was just to showcase my techniques and my results and ultimately hope to learn, which I have. So, but it is the Wild West for sure.
I agree with you. There are some positives that come from that. I've created some relationships that have spun off some other podcasts, like the Journal Club thing that I do. That came from an online LinkedIn meeting, and I've been asked to lecture because of putting some posts out on LinkedIn that people contacted me and said, hey, we want you to come lecture about that at our conference. And yeah, some device companies that have wanted to, selfishly, they want to put their product in front of you, but you never know what one little meeting with XYZ person might spin off to in the future. And so I've also been asked to lecture a few times on social media, and that was an unintended benefit, question mark unintended side effect of putting yourself out there on social media. My goal with the origination of social media was to create something that made podiatry look cool. That was like the first thing I was like, we need something out there that makes podiatry look cool. Like, that's my goal. I don't know if I succeed or not. Maybe I look like a doofus. I don't know. People listening are like, yeah, doofus. But, and then that spun off into the podcast and education, trying to make it entertaining and all that stuff. But yeah, there are some unintended side effects out there, like putting your name out there and becoming a guest on Pod Patrol. So
Yeah.
maybe that was secretly what you were hoping for.
Goal. And honestly, I mean, I think this podcast is such a cool platform, and I couldn't even imagine how it is to like initiate a podcast, let alone to grow it to the level that you have. So, I mean, I think that's incredible.
Yeah,
I think it's awesome.
Appreciate that. It was like full on dork mode. I was buying books like how to start a podcast. Literally and I'm watching videos like, what light do I need to buy? What microphone do I need to buy? Then once you do it all, you're like, oh, it's not that hard. You just put all this stuff and then you hit record, and it's really not that hard. It's time consuming, but it's not that difficult. So yeah, it is difficult, or it is a steep learning curve. I'll say that it's a steep learning curve to learn how to do a podcast. But once you figured it out, it's kind of like all the surgeries we do.
Yeah.
Very steep learning curve. These complex trimal ankle fractures. You can't just take anyone off the street and say, hey, go ahead and fix this. You're like, what's going on here? But once you learn it, you're like, well, I can tackle. Oh yeah, you see the x-ray, ED sends you a picture. I can handle that. No problem. So maybe a little parallel there to our everyday lives. So what are your favorite cases that you like to do in the OR?
I think for me, a lot of it is just the trauma, just generally speaking. I don't care if it's a toe dislocation versus a complicated open talar body fracture, whatever it is. It's just the unknown that walks through the ED and you getting the call at 2 or 3 in the morning and just putting on your critical thinking cap. And those are the ones that kind of get me really excited, and I think why I love our profession so much, and at least in our domain too, since we're so specialized within the foot and ankle, that I feel like we're kind of set for anything, but I think that's the stuff that makes me the most excited. And in my practice is super. It's just at a point right now where I think like literally 90% of what I do is trauma, and then 10% is bunions. There's like, it's just how it is. I don't understand how that works, but right now obviously that can change. But right now it's just trauma and bunions.
It's a good combo.
Yeah.
You're still young. You still eat up all that trauma stuff. I used to love all that stuff, and then it'll fade. It'll get to the point where you're like, nah, I just want to go back to sleep. Like, I don't know, call someone else. I just want to, what is it? Yeah, no, absolutely
just
not.
Reduce it.
Is there anyone else you can talk to?
Yeah.
That fades with time. But yeah, when you're young and hungry and coming out, you're ready to tackle the world. And then you kind of do a few of everything, and then you're kind of like, all right, I've been there, done that. And so, I still like to do trauma. It's still a decent chunk of what I do. But the 2 or 3 a.m. phone calls, not my favorite. So what do you think about jumping into some cases and then using these cases to spin off and talk? We're going to take the deepest dive possible into ankle fractures. We're going to talk everything ankle, and let's just jump into these cases, and then I think that'll help spur some discussion on all the directions that we can go.
I love it.
We'll be right back after this. For more information, go to podiatrygrowth.com/podpatrol.
So the people have signed up for the 5 email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plans. A really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatrygrowth.com. If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol. Case number 1, talk me through what we have here.
Yeah.
And
So this,
keep in mind, there's a big chunk of people who are too lazy to actually watch the podcast. They just listen
there is
to
listening.
us. Yeah.
So I'll try to explain it as good as I can for at least the listeners. But this is, I remember this vividly. This is about almost one of my first cases where I was implementing intramedullary fixation, and this is like kind of like the classic case for anyone who's probably getting into MIS. Is this might be an ideal case, right? So this is a patient who walks in. She comes in my clinic, weight bearing on this thing. Obviously, you can see by the body habitus. I mean, this person has severe lymphedema. 450 pounds, morbidly obese.
Yeah.
You're like,
that's tough.
darn, there's no way I'm making an incision on this. There's no way that incision would heal.
Yeah.
But,
Never get that closed.
Yeah, right. And I felt in this particular case, in order for the functional result to be the most, there's a low Weber B displaced fracture. There's some gapping. You can see the shortening and rotation slightly. I think we did some stress imaging too. I don't know if we added that, but there was some gapping immediately too, where I'm like, I think this is indicative to bring to the OR. And we can probably do this MES. And this is the one we're actually brought in the next day. So I brought her in 2 days after because I'm like, there's no way that I'm going to wait a week or two for that fracture to get sticky and I'm not making a decision. So this is the one we're actually opted to do purely percutaneous.
So for anyone listening, like you said, it's kind of it's an oblique Weber B, not significantly displaced. And I don't see, it's hard to tell, but I don't see any posterior malleolus fracture or any medial malleolus fracture. So when you see an X-ray like this, what are your thoughts on fixation options? So obviously we talked about her body habitus led you more towards a small incisional approach, like a fibular nailing system as opposed to a lateral plating system. Are you concerned about, keep in mind, we got a lot of younger listeners. Is this something where you care about the syndesmosis? Are you going to stress anything medially? Or are you just going in and you're just focusing right on that fibula? Or are you going to fix the fibula and then stress things? What's your initial thought process?
Yeah, when I see kind of gapping, I suspect there's probably a superficial deltoid component to these, these rotational injuries. I feel like a lot of these ankle fractures that don't have a medial malleolar fracture, there's a probable superficial deltoid component that is, affecting the integrity of this joint. In the syndesmosis, it's, in this particular case, the low Weber B, it's kind of at the level of the ankle. I don't see any overt instability or dislocation. It's likely stable. But in a situation where I'm definitely not making incisions, I'm probably going to throw some screws across the syndesmosis to indirectly stabilize the deltoid, even though in cases that there is a deltoid injury, I am very aggressive in just putting an anchor in the anterior colliculus too. This case, I'm not making incisions, so I felt like the most appropriate was probably just indirectly addressing the deltoid by putting a couple syndesmotic screws across.
Sure.
Yeah.
So here's our post-op films. Talk through what we're looking at there and what you did.
Yep. So we were, with these purely percutaneous approaches, which again I do maybe 1% of the time. I just don't do it very often. But again, this is a kind of like a classic case where no one's making an incision.
So clarify that when you say no incision.
Yep. So essentially, I'm not making an incision at the level of the fracture and putting clamps and reducing it.
Yep.
So this is one where I believe this is a situation where I put on a Hinterman, a wire kind of distal and proximal to the fracture, distracted it and got it out to length. And I'm always getting comparative films. So this is a situation where I have her contralateral ankles in the OR2 just to ensure. But yeah, this is one where we reduced it percutaneously, felt it's appropriate. And then as I'm putting the Hinterman stays on, then we're throwing in a fibular nail. and putting the distal interlocks in, stabilizing that nail in place, keeping the length, the alignment or rotation in place, and then knowing that there's likely superficial deltoid component to this and no overt syndesmotic injury, I'm still putting those screws across in 2 because she's 450 pounds.
Yeah.
It made me feel better. It's indirectly addressing the syndesmosis, and that established this nice stable mortise.
So when I've long been a proponent of indirectly stabilizing the deltoid complex with syndesmotic fixation. And so specifically, I usually don't use syndesmotic screws except for certain diabetic population or obese population. Obviously, I don't know. Does she have diabetes? Do you remember?
She did not. No, she was actually healthy, 450 pounder.
That's an oxymoron.
Yeah.
I don't know if that's possible, but she in Arizona, I guess that's the only place you're going to find that, because anywhere else, and that's not the case. A lot of comorbidities going on when they get that big, unfortunately. So,
yeah.
What was your thought process on this for using the syndesmotic screws versus flexible fixation with an intramedullary fibular nailing system like this?
Yeah, and I think the whole thought process with me is knowing that, just 450 pounds of weight and the amount of load that's going across an ankle, I felt, I wanted that initial stability with the screws, because I knew that she's in a boot day 0.
Mm-hmm.
So I knew she was going to be weight bearing right away. And so I felt like the screws would be most appropriate, but I'm with you. I mean, the majority of cases I'm using flexible fixation just because I think the malreduction rates are significantly lower. I think research shows their superiority for the majority of cases over screw fixation.
Yeah.
In regards to the deltoid, I'm super aggressive in treating the deltoid with suture anchors.
Mm-hmm.
But again, I knew this is a situation where there's no way I'm making an open incision on this skin. It just won't heal. And so I felt like indirectly addressing the deltoid with these screws was an appropriate treatment.
So just to clarify my position, I will fix the fibula and then I will stabilize the syndesmosis. If there was some medial clear space, I can suck that down with fixing the syndesmosis, and then I will stress it again and see if there's any instability immediately, and then open it up and fix the deltoid. That's just kind of my staged approach of things. So I just wanted to throw that last part in there about testing it again, stressing it again. Absolutely. After you fix the syndesmosis. I think sometimes people fix the syndesmosis and then they're done. They leave. I think it's important to fix the syndesmosis and then stress it again, because I've had it happen a few times. Not that common. Usually when I stabilize the syndesmosis, it locks it up and I don't have any residual instability, but I've had a few times where I do have some talar tilt that opens up immediately, consistent with probably more of a deep deltoid instead of just a superficial deltoid, maybe a deep deltoid tear that leads to more significant talar tilt and instability there. What are your thoughts on stressing before, during, after, all the above?
Oh, I'm with you 100% on that. Like I'll essentially fix the fibula first in a case like this. I'll stress if it's unstable. I typically do the deltoid first.
Okay.
And then I'll stress after that, and then I'll do the syndesmosis, plus or minus the scope. It just depends on the age population. I think that's a whole different conversation in and of itself. But I'm definitely stressing after I repair the deltoid. I stress again after I repair the fibula. I think that's critical, because obviously we know, I think research shows, do we repair the deltoid? I think that's still very controversial, but it is, if it's torn, if there's any degree of instability, I don't see the con of going in and fixing it. I think there's research out there shows if you don't fix it, I mean, within 6 weeks, 90% of plus patients can develop, hindfoot valgus, and so it's just one of those things where I think you can prevent a lot of sequela in the future if we just fix it.
I agree with you, and I feel the same way about the syndesmosis. If something is borderline, I will go ahead and stabilize the syndesmosis with flexible fixation, because if you don't fix it and there was an issue and you start to get diastasis, it's a big headache. They start to get like this synostosis formation at the syndesmosis, and it's way more complicated to treat than if you just stabilize primarily. And the same is true for the deltoid. If you miss a deltoid injury and they start to get late valgus tilt of their hind foot, that becomes so much more complex than just primarily fixing it when you're there the first time. So I agree with you. I think it does add time, and there is a complexity component to attacking the deltoid. I think people are very used to spending time at the lateral ankle. We don't get as intimidated over there because there's no neurovascular bundle. But as soon as you start going medial with the saphenous and all the neurovascular things that we're taught to stay away from on the medial aspect, I think that does intimidate people somewhat. Why do you think some people don't fix the deltoid?
I think a lot of it is just because, they got a stable equidistant mortise after fibular fixation. They may not even stress it.
Sure.
I think that's the biggest thing, is just not stressing. And I think if more people stress and they make it common practice, I think they'll find themselves addressing the deltoid more commonly. But there's also research out there that shows that, you don't have to fix it. But then you look at the newer evidence and it's like, well, I think maybe we need to reconsider.
Yeah.
And so I think a lot of it too is just adapting to what the evidence is showcasing too. And I think that's really important, especially in our line of work when we're doing these surgeries and we have patients kind of, who are relying on us, just pursuing evidence-based medicine and kind of doing what you think is best for the patient. I think repairing the deltoid, if it takes an extra 5 minutes, do it. So.
Absolutely. So this is not that patient, but I threw this video in there for anyone watching on YouTube or Spotify, actually watching the video of insertion of this fibular nailing system. You want to talk about the reason I know it's not that patient? Number one, body habitus.
Right.
Number two, there's an incision with a clamp over it. But you want to talk through what we're looking at here with this video? I thought it would provide some clarity for anybody watching to see the intramedullary nail go in, and then we'll jump into some more cases.
Absolutely. So this is a pretty typical case for me. I think what's important is, you have about a 1.5, 2 centimeter incision with a clamp on. It's reducing the fracture, and it's in place during the entire insertion of this nail. I think what's kind of cool about this system is you can see I'm putting in like a screw, right? And so I'm not tamping, I'm not malleting it, which can oftentimes, or at least what I've noticed, is if you're not paying attention to that fracture site when you're implanting that nail, you can get a slight shortening and rotation. So the ease of insertion makes that a little bit easier and reduces any potential risk of shortening and rotation when you are implanting it. And so that it's kind of a neat, novel system that allows a little bit more precision with implantation.
So a couple things. When I first started using intramedullary nails, I had anticipated the ability to reduce the fracture with the nail. I did a lot of orthopedic trauma, and we do tibial fractures and femoral nails and all kinds of nails that you would use to reduce the fracture, because the ratio of the width of the nail to the medullary canal made it such that it almost had to realign the bone and pull it back into alignment. With the distal fibula, the anatomy with the distal lateral angulation at the most distal component, at least the nail I was using was a bent nail, and so it impacts. And so when you put your, even if you're able to get some manual reduction, some manual manipulation, or maybe it was an older patient who didn't have a significantly displaced fracture and I didn't have to do too much reduction, I would put the wire in, everything looked fantastic, and then I would impact the nail. And just like you said, it would cause some either distraction or some angulation because you're putting a bent nail into a bent structure over a straight-ish wire that's following the contour of the bone. And so I did change pretty quickly to making a small incision over top of the fracture, cleaning it out, and then leaving the clamp on during implantation to prevent any rotational changes or, like I said, diastasis or impaction and shortening of the fracture. I think that's an important thing that I didn't fully understand when I first started using intramedullary nailing systems. I think that's an important point there. Is that something that you're almost, aside from the first case, almost always doing?
Yeah. Yeah, and I mean, I get these ankles too within about 24 to 36 hours, and I'm bringing them to the OR right away. So it's pretty rare when I even do delta frames anymore, unless there's significant soft tissue compromise and a high velocity injury. But I see a lot of low velocity injuries, and swelling is no longer a factor that, requires me to wait a few weeks, So, and it makes reduction and, super easy when they're fresh.
For sure. What's your technique for opening up the fracture and getting your reduction through a small incision? I know what mine is, but what's your technique for obtaining the reduction?
Yes, I always use fluoroscopy. I put a FREER kind of rate on the level of the fracture. I confirm it via X-ray, and that's where I'll essentially plan my incision. And so I always try to make sure that, especially if it's like a long spiral oblique fracture, I'll try to get it on the posterior apex of that spike to ensure, because then I can look at where it's lining up to ensure I get anatomic reduction. But usually it's all confirmed via fluoroscopy with me.
Yeah, I am a bigger fan when it has that posterior spike
Mm-hmm.
because I feel like I can make even like a 1 centimeter incision and kind of like stick the clamp in sideways, rotate it, get it around the bone, and do this like spinning distal, like clamp spin distal technique, and then clamp it down. It's like it's second nature now. I've done it so many times where you just stick the clamp in, you do this spin distal to get your length and clamp down in like 4 seconds, and you're like, check the
Yep.
fluoro, like boom, done, easy. But some of them, if they don't have that posterior spike, that's a little harder to get your length on those, and you might fight that a little bit more. Or if there's comminution, so let's say that there was a posterior butterfly fragment or any amount of comminution, does that make you not tackle it via nailing technique because it's going to be harder to get your reduction percutaneously? Or what are your thoughts on comminution at the fracture site?
For sure. So I've evolved. I know in the beginning that was a contraindication with me when it came to nailing, but then over the course, obviously when you use a system for so long, you get more comfortable, you expand your indications, you evolve. And also, I mean, I'm not afraid to extend my incision. I might go 5, 6 centimeters. I really don't care because there's no underlying plate. So wound complications for me they're not super common. I don't remember the last wound complication I've actually had with one of these because there's no underlying plate. So if I want to get a better cortical read, I'll just expand my incision, both distal and proximal, to ensure I got reduction. Of course, I'm always getting X-rays of their contralateral side too, and making sure that that's up in the room so I can kind of compare and contrast a little bit. And then if I'm having trouble, especially in like these comminuted bones, are typically osteopenic, I get my length right, but I'm having trouble holding it. I'll just pin the distal fibula to the talus or the distal tibia to kind of keep that out of length, and then we put on the guide wire for the nail.
Mm-hmm. I think those are good tips. A couple of things. I'm going to jump to the next slide, but then I'll have a couple more questions for you here. So I know the answer because I saw the nail. I know what nail you're using. What are your thoughts on a bent nail versus a straight nail?
Yeah, it's I have a couple things. I know with bent nails, it doesn't really make sense to me with these bent nails, and the reason why I say that is because, I mean, just looking at this mortise view on the left side, I mean, when you actually draw a line and you have a good mortise, the fibula is actually straight, right? It is one of those things where it took me a while to kind of wrap my head around that, and I started questioning, like, does it make sense to put this bent nail with the 5-degree valgus bend for the most part? I think a lot of them are, 5-degree valgus into a straight bone. And obviously these valgus nails, they work. You just have to, it all depends on where your starting point is. So you're kind of limited to starting your guide wire with these bent nails, the distal lateral. With more of a straight nail, you kind of have more play with it because it's straight and they tend to be more conforming to the anatomy. And I know some fibulas are different. Not every fibula is straight. Some have very unique morphology. And I think a bent nail might be indicated in some cases, but I just found that in the majority of cases, if you have a good mortise view, the fibula is oftentimes straight, and bent nails or pre-bent nails aren't really necessary.
So for anyone who hasn't put in a fibular nail before, would you equate this to fixing a Jones fracture in terms of wire positioning? Don't fire it until you're sure that you're center on AP or mortise and a lateral. And then, the reason is for the younger people, if you make a wrong hole, the wire wants to find the wrong hole again. So what are your tips for starting the wire, only throwing it once and getting it into the proper position? What are your thoughts on what you're looking at radiographically?
Oh, 100%. And please learn from me. It's very similar to a Jones fracture, high and inside, obviously for the Jones, but for this, you essentially got a good stack of towels on the distal leg, and that kind of inverts the foot, gives you good mortise interop. Put the wire in on the AP. AP sometimes looks fantastic. A lot of you're like, oh my gosh, I'm in the perineals. Don't, just be cognizant in the beginning, mark out the anatomy. So for me, I still mark out the anatomy. That's still something I do every single time because that helps my initial guide wire placement.
100%.
Just put it, just put in the distal fibula, get an AP, get a lateral. If you're good, drive it up. And I use a mallet. It just finds the path of least resistance or oscillate.
No, yeah, I oscillate.
Yeah. And if you're not good, they say you're good on the AP, horrible on the lateral, a lot of these systems have some sort of parallel guide or something that allows you to change one particular plane with your wires. So instead of making 4 or 5 drill holes, which I've done, don't do it. Just make another hole with the parallel guide. And you can get a parallel guide if your system doesn't have it. You can get one from a Jones fracture set or talk with your rep and be like, can I have any parallel guide? They all work quite well.
I really like a parallel guide, even though it feels to me like I'm admitting defeat. I feel like I'm really good at throwing wires, and when I get one that just looks terrible, it's admitting defeat. But the main reason in my mind that it makes 100% sense and you be stupid not to use it is if you use a parallel guide, the new wire can't find the wrong hole because the last hole is full of a wire. So it's a little bit dummy proof in terms of like, well, I know it can't go in that hole because the wire is still in that hole. So That's where it makes the most amount of sense to me, even though it feels like I'm admitting defeat.
Yeah, no, for sure. I agree 100%. That's why I didn't use it for like my first 10 cases. The rep's like, we have this parallel guy. I'm like, nope, I got this.
Me too. And I was like, nah. And then eventually I realized, well, if I use it, then it won't find the wrong hole. And we'll be done with this case a lot sooner.
100%.
The last thing I want to touch on before we talk about a bunch more things, but something that came to my mind because you mentioned it earlier, is scoping ankle fractures. How often are you scoping an ankle fracture, and why yes or why no?
I would say probably, honestly, I don't do it as much. I kind of reserve that for the higher end, probably athletes, maybe the 18 to 30-year-olds, if I really had to give a general age population or cohort. I think it's one of those things where I'll add in someone where I want maybe an extra documentation because I can confirm syndesmotic instability with the drive-through sign or medial instability with the positive drive-through sign. I can take pictures because those are usually the patients that want to know everything about everything and when they want to know the exact date when they can get back on the field. So I think if I can do a scope, that gives me far more valuable insight. But also, I mean, I think there's evidence support. Just by putting the scope in there and lavaging it, you get rid of all these, proteinases, which can cause chondrotoxicity and all that type of stuff too. So I think that's something that might be contributing to ongoing pain in patients I'm not scoping. So I think it's definitely something I've considered scoping in more patients. I just haven't got around to doing it. But right now, I reserve for like the higher end athletes and younger patients.
Yeah, I don't scope hardly any. I think my indication would be is if it were more of like a intra-articular comminuted, tibial plafond type fracture where I'm checking reductions and looking for maybe some more significant injuries, osteochondral defects, something like that. I think the argument is there to scope.
Mm-hmm.
I don't have a good reason why I don't. So
Yeah.
every time I say that, I'm like, you know what? I should start doing it. You know what? To be honest with you, I just think, let me get in here, fix this fracture, boop, boop, done. 10, 20 minute, whatever it takes me to fix the fracture, boom, out the door, moving on to the next one. So part of it is it just doesn't even cross my mind. But
Yeah.
what I also think about is if you're not looking for something, you're not going to find it. So there could be some interarticular pathology that if you don't go looking for it, you won't know that it was there or not. So I think there is some indication for scoping more of these, and that may start to be a bigger trend moving forward if I had to guess.
For sure. And I think a lot for me too, why I don't scope everyone is, the hospital. I mean, every time I do a scope, I mean, it's like, National Guard gets brought in. I mean, it just becomes a big hassle. And I try to avoid that at all costs too. So
I did a scope today and they were training someone new and it was like, it was pulling teeth. I always joke with my student, the thing I say in the OR, and they're going to put a plaque of me on the wall at my hospital with this quote under it. I say, it's the first time every time. Every single case, it feels like it's the first time anyone in this room has ever done this case. Why does it always feel like the first time every time? Drives me absolutely bananas. All right, let's bring back to this case here. So this is that same large patient that you did the intramedullary nailing on. So tell the people listening what happened.
yeah, so obviously, I don't think it was a surprise. We got one of the syndesmotic screws, the most distal one, close to the ankle joint, that fractured. And I tell everyone, if I ever do screws, your screw will break. I don't know when it will break, but based on the research, if it breaks, you get restoration mobility at that joint, and you'll oftentimes be asymptomatic.
Mm-hmm.
As long as I set the expectations early and they know, they're less likely to request, can you please remove that implant?
Right.
I feel like if I don't tell them and they see it, they're like, oh my gosh, I need to remove that.
How often are you having a conversation? So what made me think of this is setting expectations. And so I worked in Pittsburgh with one of the top orthopedic trauma surgeons in Pittsburgh and maybe the world, Dr. Gruen. Shout out Dr. Gruen. But he would always set the bar like super, super low. He's like, your ankle was a mess. I put it back together perfectly. If you walk on this, you'll become a cripple and I'll have to cut your leg off. He would also throw in, your fracture was like a bag of broken potato chips and I put it back together almost perfectly. He'd say the same thing to all these people. You set the bar so low. But where I'm going with that is how often do you have the discussion about post-traumatic arthritis?
I think I do on all my tri-melts in particular, because I know there's a direct correlation with obviously the higher energy, the more malleoli that are typically involved. If there's any posterior subluxation of the talus, those are the situations where I tend to have more of a conversation preoperatively. And these are patients I'm seeing in the hospital. I'm doing surgery on them almost right away, unless there's obviously caveats to that. There's a big posterior mal where I need the soft tissue to stabilize. I typically make big incisions for the posterior mal. I have conversation with them pretty often saying, hey, in 5-10 years, post-traumatic ankle arthritis is a little bit different than primary versus knees and the hips. It's not you won't know about it until 5, 10, 15, 20 years down the road, but it may happen and you may be asymptomatic. But I just want to at least put in your mind, based on your energy, your fracture pattern, there's a probability in the future you may need some secondary surgery.
Yeah, for me, it really depends on the fracture. If someone breaks their calcaneus, I tell them you 100% are going to get arthritis. I don't know if it'll be next week, next month, next year, or 10 years from now, but you will develop arthritis. With ankle fractures, I don't tend to have that conversation as much. I do try to put that little bug in their ear so that, if it does develop, that it's not the first time they're hearing it. Hey, remember, we talked about this. We knew this was most likely going to happen. And so, like you said about setting the stage of talking to people about that syndesmotic screw breaking, people that are made aware ahead of time tend to absorb that information a lot better than if they, well, you never said that this could happen and I never knew, like that. Those conversations are much harder than if you had set the groundwork ahead of time. So I'm kind of talking to the younger people when I'm mentioning this, but setting the groundwork with your patients about outcomes and expectations is very important, because when you're young and cocky, you're going to say, I put your ankle back together perfectly. Look how perfect it is. Look how good I am. Wow, what a great surgeon you must have had, which is fine. You can do that, but also setting the, groundwork for what can also happen down the road, I think is important.
Yeah. And it's a humbling experience, especially when, you feel like you did a good job. And I just had a case where I did a calc or AF and the joint looked pristine. And then a year later, they're like, I have ongoing recalcitrant pain. I'm like, yeah, your subtalar doesn't look that bad. I mean, there's obviously some joint space there, but sometimes they can, surprise you too. So
Calc is the worst. Calc is the
it's the
absolute
worst.
worst. That's why I tell people, like, this is going to get arthritic. We just don't know
Yeah.
when. I tell people the second that you fell and broke it, you got yourself some arthritis.
Yep.
It was going to happen. I'm just going to try to fix this and make it as pain-free in the meantime. But the second that you fell and broke that, you just got arthritis.
For sure.
So what was your plan with that lady? Leave it alone?
Yep. And so she remembered our conversation, a year prior. These x-rays are 1 year out. And she's like, you know what? I'm not in any pain. I don't feel it. I think I remember her saying I got a little bit more mobility back. It was still stiff, but she was asymptomatic. So she just wanted to leave it in place. And I was completely okay with that.
She went back to dunking a basketball?
That's exactly what she did.
Good for her. Good for her. All right, moving on. Case number 2. Tell the people what we got going on here. This one gets a little more complex.
Yes. So that was kind of my goal with these cases, to start simple and kind of work our way up. So this is one where I want to say this is a patient. I was unable to get a CT scan on her because at the time of this injury, she was pregnant, and she just didn't want any additional imaging, despite my best efforts of saying, hey, like, you have what appears to be a trimalleolar ankle fracture, trimalleolar equivalent. There's no obvious medial injury, but I said I'd feel more comfortable. It would allow me to get a lot more insight and get kind of a three-dimensional model of this fracture, because I'm concerned there's a posterior malleolar injury. But despite my best efforts, she refused, and it's understandable. But so I kind of knew going in that, with my approach to these posterior malleolar fractures, these are the ones I always open, and I always go through a medial posterior medial approach.
Okay.
So these are ones where I wait 2-3 weeks, just depending on the soft tissue stabilization.
So this would be a good time, because we'll go a lot deeper. Tell the people what a medial posterior medial approach is. Where is your incision? What anatomic structures are you identifying and moving?
Yeah. So for me, I know that there's a lot of work now, by Lennon Mason out of Liverpool. He has a good detailed approach to this, but you're essentially at an interval between the posterior tibial tendon and the flexor digitorum longus, and you're kind of on the posterior edge of the malleolar groove and kind of the distal medial tibia. And so you're at that interval, and if you identify the sheaths of the posterior tibial tendon, the FDL, you open them and you retract the FDL and the neurovascular bundle, all lateral. So you never see the neurovascular bundle. So, beginning when you first do this approach, you're kind of nervous, but then the more you do it, you don't see the neurovascular bundle because it's protected during the entirety of the process. And you can actually see the entire posterior tibial plafond. It's like quite incredible the exposure you actually get. Because I don't do posterior lateral anymore. That was like my go-to approach. But then patients just had ongoing stiffness and wound complications, and it was just a nightmare. So I stopped doing it and abandoned it completely like 2 years ago.
So what are you using to retract?
So usually I do use I like blunt sends versus I actually will sometimes put K wires and bend them, kind of like your lateral extensile approach for calcs.
Mm-hmm.
I've done that
It's a good
just to
idea.
kind of reduce tension at the skin and then
Yeah.
reposition them throughout the case if I have to.
I like
Because I
I
don't
like
have
an
assistance.
I like an Army Navy, but I
Yeah.
like that K-wire technique. That's a good idea. I had another question. Talk about the difference between the medial, posterior medial, and the posterior medial approach. So
Yeah.
what are you saying that's different than typical posterior medial approach?
Yeah, I think if you have like a posterior malleolar fracture with maybe some medial malleolar extension, or you're kind of in that posterior malleolar groove, if you do a posterior medial approach, which is an interval between essentially the FHL and the medial Achilles, you have excellent access to the entire posterior plafond. But if you have any extension medial, you start limiting your exposure, and you have to make a separate incision. I found that. And so so that's why I've kind of completely abandoned those two approaches almost entirely for posterior malleolar work and just went right to the medial posterior medial approach.
Are you doing this via prone? Are you doing this via what? What are you doing?
So I do a prone. It's kind of what I feel comfortable, because for me, it's mostly my screw trajectory when I am putting in the hardware. I know some people frog leg, some people somehow do it supine, which I don't know how that's even possible unless you have an assistant who's raising the leg up and you're putting the screws in that way. But for me, it's just prone is just super easy. But now I put these fibular nails in prone, and so I don't have to reposition the patient supine.
That's nice. Yeah, it is difficult. So when I've done the medial posterior medial approach, I agree with you. You can see the entire posterior plafond. You get good visualization. But if I've ever done it while the patient is supine, I try to do like a sloppy frog leg thing. It's really, really hard to get good fixation from that angle. So even though you can get access to it visually and you can reduce it, it's really hard to get fixation across that, aside from throwing wires. You can throw wires, but trying to get a plate, like turning your head upside down, trying to look back up in there, I mean, it's a battle. So I think either learning how to fix the fibula while the patient is prone, which is not that complicated, especially if you're doing a lateral. I mean, I guess it doesn't matter whether the fibula, the front of the fibula is facing up or down. You're still going to the lateral aspect of the fibula, so it's not that complicated. But yeah, what are the biggest challenges you think of going prone, other than everything is kind of reversed?
Yeah, I think that's the biggest thing, is getting used to the X-ray and just everything in reverse and getting used to it. That was my biggest thing in the beginning. Like, what the heck? And then also trying to, if there's a medial malleolar component, trying to throw those wires prone. In the beginning, it's like, geez, am I a rookie? Like, you look like a moron. So it's just a matter of getting used to it and being comfortable, being uncomfortable for your first couple ones. And then it just becomes almost like second nature again.
Mm-hmm.
But it takes some getting used to for sure.
All right, let's jump back to this case again and start. So we couldn't get a CT, couldn't get any advanced imaging. We know we have trimalleolar components of the ankle. The thing that worries me is when I get a CT scan, if the fracture warrants getting a CT scan, which means I see something that looks abnormal, it always gives me something that I didn't know was going on. It gives me like a bigger posterior malpiece or some sort of die punch fracture or some component of information that I did not or could not appreciate on x-ray. So it makes you a little bit nervous to not have that additional information when you start tackling something like this.
Yeah, that was my exact thought. And that's why I was comfortable proceeding, because I knew the approach is going to give me direct visualization. I was kind of prepared for anything. I had every single plate available. I had all the screws. So I just told the rep, just bring the entire kitchen sink, because I don't know what I'm going to do.
Right.
So, but I didn't know I was going to use a nail. I didn't know that. I'm like, we're good on that. I don't care about that. The posterior mal got me a little, unsettled. So yeah, I just prepared for it.
So talk us through what we're looking at here.
So here we have some, final intraoperative spot images. So this was actually this was a 2B Mason and Malloy posterior mal. If anyone's familiar with that, I would encourage you to look into it.
So say that again. That's the Mason and Malloy
2B fracture pattern of the posterior malleolus. And so there's a posterior medial and a posterior lateral component. You can kind of see the posterior lateral component on the lateral. I didn't actually fix it because when I went in there, it was very, very small and it was super soft. And I put a wire through it. I'm like, if I drill through this, it's going to blow out that posterior lateral component. So I just left it kind of floating.
Mm-hmm.
And so, but we did fix the posterior medial because that was the bigger component of this 2B fracture.
Yeah.
So I have the anti-glide plate proximal, and I have an additional anti-rotation screw that's going kind of from posterior medial to anterolateral. And there actually was, to my surprise, despite the preoperative images, there was a very mild medial malleolar fracture too. Mm-hmm. So that explains the partially threaded cannulated screw in the anterior colliculus there.
So what would you do on this fracture? I don't know. These are your final x-rays? No. These are your finals?
Yep.
What would you do on this case if you needed to throw syndesmotic fixation? Do you throw a wire through that first and then tackle your medial stuff so that you have your space reserved for syndesmotic fixation? Because you can alter the medial fixation. Can't really, a little anterior, a little posterior, but you can't angle the syndesmotic fixation too much.
For sure, yeah, and I'm kind of planning because I know I'm going to fix the posterior mal first, just because I don't want that to be obscured with my fibular fixation. So, I will plate everything first, and I will essentially, I'm kind of planning ahead, throwing screws and placing plates, ensuring that if I have to do any syndesmotic fixation, that it's going to provide me the best chance, so I'm not going to interfere with any sort of screws and or flexible fixation later on when I am doing my fibular fixation. Mm-hmm. So I'm trying to plan for that for sure, and I try to keep it a little bit more posterior because I know when I do my syndesmotic fixation, I do kind of like a central. I get a lateral where the fibula is within the central axis of the tibia, and then I'll drill on a lateral and set up your typical mortise and ensuring to be parallel to the mortise on that view. So
she was pregnant when you did this. Did she name her baby after you?
I hope so.
She should have. You hooked her up.
So yeah, it was I was concerned because, obviously being prone for a prolonged position, I forgot how many weeks she was, but I said, you know what, the best thing is to just stay in one position the other time. And this is actually one of my first cases where I started doing these nails prone as well. Mm-hmm. So.
All right, let's jump ahead here to case number 3. Yes. What do we got going on here for the people listening?
So definitely a little bit more involved here. This seems to be like a similar case to the first one. Fortunately, the patient was not pregnant. So, but we have a, non-wavering images. We got a kind of a longer oblique fibular fracture, which we can clearly see on the lateral, but also this, I've learned this actually about 2 years ago, this misty mountain sign on an AP where you have like these shadows in the posterior distal tibia. And anytime I see that, I'm like, okay, there's a posterior component there.
100%. I was looking at that too.
Yep.
Whenever I see exactly what you just described, I think there's something big going on back there. Not that little wafer thin posterior mal type fracture, but something more significant going on back there.
Yep. And this is the one where I'm like, yeah, I'm definitely, getting the CT scan. There's something going on that's going to be significant. That's likely going to change how I approach this.
It's interesting because I think that it's kind of like a wine connoisseur. When I drink a $4 bottle of wine, I can tell you it's gross. And if it gets beyond maybe like $20, I'm like, yes, it's amazing. And I don't know if it's $20 or $300 or more. I just can't tell the difference. And the same is true when you look at enough x-rays. When you become an ankle fracture connoisseur, then you can start to look and pick up on things that most people will miss. And when I look at that x-ray, I can almost see there's like an interarticular split of the tibial plafond with a little bit of tilting of the posterior aspect of that posterior malleolus. And most people would not, I'm not tooting my own horn, but toot. Most people would not pick up on that. But it's interesting that the more you do something, the more crazy, random, anatomic variant type things you see, you start to pick up on the subtlest of little things that most people would miss. Even radiology, no offense to them, they're doing 10,000 reads a day. They don't have time to look at every little nook and cranny like we do. And this is all we look at all day long. But you can start to pick up on these little things, like you said, the Misty Mountain sign. I like that, where most people would look at that and say on the AP, they'd be like, oh, isolated distal fibula fracture, right? But when you look at the lateral, you start to think, I don't know about that. I think there's something else going on there.
Yeah. That's exactly what the ED physician said. Hey, we got an easy isolated fibular fracture for you. Interested? I'm like, let me see the x-rays. I'm like, yeah, I don't know.
Exactly. I've been down that road too many times. It's like, let's dig deeper before we start, high-fiving too much. So tell the people listening what we see here on our CT slices.
Yeah. So here we got the sagittal. I took a sagittal of the fibular component, and also the sagittal of the posterior mal component. So then we have the axial on the far right. But, we have a pretty significant, we have a longer spiral oblique fracture of the fibula, and then we're kind of showcasing the posterior lateral component of this posterior malleolar two-part fracture. There's some proximal displacement. Fortunately, this was just displaced. There was no intercalary fragment or anything that might be holding up reduction or any significant comminution. So
tell people,
that was reassuring.
I want to hammer down on that. Tell people what you're talking about when you talk about that. I call it a die punch fracture, but talk about what you're talking about more specifically.
So yeah, absolutely. So that die punch or intercalary fragment, usually it's a component that kind of gets jam packed into the fracture that can impede any sort of reduction if you see that on the CT scans, it's clear that you need to open, or you can actually, I know there's people do it arthroscopically now, but that can, if you don't address that, can cause malreductions and lead to poor functional outcomes.
I had a lady one time, she had a die punch fracture that was impacted and 180 degrees rotated, like completely upside down, jammed up inside. I could see it clear as day. You could see the articular surface of the tibial plafond facing superior with that little fracture fragment. I'm like, how did you do that? I don't even know how you spun that little fracture fragment inside of your tibial plafond fracture. And so I told her, we have to open this. This is not your run-of-the-mill ankle fracture. We're going to have to do some work here. So what is your goal when you have that die punch fracture? Are you trying to realign it? Are you removing it? What's your goal?
I think most of the time I feel like I'm actually just removing it. Me too. I feel like I don't have big ones where I'm going to, and to be honest with you, even at least in my experience, if I have good exposure, through the medial posterior medial approach. I mean, I truly, in majority of cases, don't even have good visualization of it. And so I'm really relying on that CT scan. But if it's large enough, I think out of two cases, I'm utilizing, fluoroscopy and getting a FRAIR in there and kind of realigning it and bringing it in line. But it's just super rare. Then I'll throw in wires from posterior to anterior to kind of hold that in place, and while I'm ultimately plating it. But for I would probably say 95% of the time, probably more, I'm just removing it because they're typically small and just a nuisance because they're just going to interfere with you the entire time, getting reduction.
So what's your order of fixation? If we have these fractures that we're looking at here, we have that fairly significant lateral malleolus fracture, and then we have the two-part posterior malleolus fracture, what's your order of fixation?
So for me, it's always posterior malleolus first. So, and then that comes to the next question is which one do you fix first? And so I fix posterior medial first, and then I fix posterior lateral. And then what I found is that it really does aid with restoration, at least somewhat, of your fibular fracture. So it actually makes kind of reduction relatively straightforward from the fibular fracture standpoint. But what I found, but also what the research shows, if you do fix the posterior lateral first, it kind of pushes the posterior medial fragment more medial, and you'll never get a solid reduction of that posterior medial component. And so it's posterior medial, posterior lateral, and then we'll address the fibula.
This one is obviously large enough that requires fixation of the posterior malleolus. Let's say that fracture fragment was a 1 part and it was much smaller, but it was still there. And you were going to tackle the fibula, you fixate the fibula, and then you get a lateral, and you see there's still just a little bit of step off at that posterior malleolus fracture. And it's relatively small. And have you found any reduction techniques to be able to get that into better alignment via closed manipulation? Have you found any techniques to try to mobilize that posterior malleolus fragment to come down? It has to come down like 2 millimeters distally or something like that. Have you found any way to do that, or you find you have to open them to get true reduction?
I feel like, I always confirm that. I mean, if it's like a small one, I'm like really like, do I need to fix this? I tend to be super aggressive with posterior malleolar fractures, but sometimes if there's a little, it's questionable. There's some proximal displacement. I will actually, because I'm making a small incision in the majority of my fibular fracture anyways, I'll just distract the fibular fracture and access the posterior malleolar fragment through my fibular fracture. And get a little dental pick in there or some sort of joker or something and bring that down, white P, and then I'll drill A to P and then put in a screw P to A if it's partially threaded. Now I also just do fully threaded A to P screws too. So just kind of like dealer's choice, to be honest with you.
Do you find that if you put the screw in from A to P, how often do you find that the screw wants to distract the fragment?
All the time. And so that's the one where it's kind of, I'll get like 2 provisional wires in there, but also at the same time, even though it's super frustrating, I'm still with my non-dominant hand, I'm putting that dental pick through that fracture and holding that while I'm doing it too. So, but sometimes it's just kind of cumbersome. So I've been doing more of the P to A stuff because it's a lot easier.
Yeah.
So
yeah, well, it definitely maintains it reduces the fracture as opposed to distracts and displaces the fracture, even though I like the ease of A to P depending on the patient's position. But let's say that they're supine, the A to P is much easier to throw than the P to A, especially when they're supine. But the screw does want to try to distract that fracture fragment and displace it posteriorly when you put that screw in. So I like the idea of a second wire there, and maybe even at an off angle, like kind of convergent there into the fracture, just to try to prevent some of that displacement. But a lot of this is done. It's really difficult. It's so easy. I try to teach the students all the time when we're looking at the CT scan and on the X-ray, but especially the CT scan, you're looking at one slice and it looks so easy. We'll just go in and move that piece down like a 2 millimeter and just put it over. Like just put that, and you're like, get in the real world and everything's bleeding and you got, well, I can't go over that way and I need to go this way. And, I'm fighting this reduction and the whole thing's kind of flopping all around. And the real world is not as easy as it looks on this simple CT scan where you're just like, oh, we'll throw a wire there and throw a wire there and that should hold it and you should be good to go. It's way more complicated when you get in there in the real world. I try to teach the students that, but sometimes you don't understand until you get in there and actually start trying to do this stuff.
Oh, for sure. There's just always a struggle at some point, and nothing is just like boom, 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 boom. There's always something.
It's interesting. One of the reasons I like ankle fractures is I don't think I've ever seen in 10 plus years of doing this, 2 ankle fractures that were exactly the same. Like no 2 ankle fractures are like, oh, I've seen this one before. It might be very similar. There are more fractures that are more common in their patterns, but it's extremely rare that I get in there and I see multiple fractures that are, oh yeah, I've seen this exact fracture before. There's so much anatomic variability. It's like if you dropped a vase and it shattered a certain way, and then you dropped a vase again, it's not going to shatter in exactly the same way. It's going to break in a completely different way. And you would have to break a whole lot of vases to find one that broke the exact same as the other one. So I don't know, just kind of
tries.
Yeah, keeps you on your toes, doesn't it? Because of the variability in there. So what was your plan for this lady or guy? I don't remember.
So we definitely, you know, from my understanding, if I remember my final images, we definitely did dual plating. Yeah. So I got the one on the far left. That just kind of shows me my posterior malleolar reduction. You can kind of see how it did actually aid with the fibula length, you know, and alignment slightly.
Yeah.
But this is just confirming the anatomaticity of the posterior mal. That's, you know, obviously critical when you're opening and addressing it. You want to ensure that before you do anything to the fibula, you know, and then putting the fibula nail in prone again. First couple times you're like, oh, this is just annoying, like backwards. But then the learning curve is not that significant, especially if you've done posterior nails or fibular nails, supine or Jones fractures. I mean, we do hindfoot nails all the time too. I mean, if you can do that, you can do these fibular nails. They're not that challenging, and the learning curve is not that significant because we do so much nailing in the foot and ankle for the most part, anyways.
Yeah, I think if you understand the principles of nailing, I'll include Jones fractures, which is not a nail, but the idea of throwing the wire first and then stepwise technique leading up to intermedullary fixation, we'll lump those together. But if you understand the principles of what you're doing, like me, when I first started doing the nails and not opening up the fracture, assuming that the nail was going to obtain the reduction for me, that was a mistake. You learn those things as you go along and you understand the principles. Then yeah, the technique I don't find to be overly challenging. Once you've done a few and you understand what you're doing, then I agree with you that it's not overly complex.
Yeah. I will say something on these images too. Now I do add an additional screw in that anti-glide plate distally as an anti-rotation screw. So that's just something I've been doing now over the last year. Just gives me a little more confidence that fracture is going to be more stable. So, and it takes an extra like 2 minutes.
Sure. So you've plated here straight posteriorly and then mostly straight medially, yes?
Yeah, it's one of these anatomic plates that was designed based on CT scans. It has like this. It's just above the posterior malleolar groove, and then it kind of wraps around the medial mal or the medial distal tibia posteriorly. It's a cool plate designed based on the anatomy of many patients based on CT scans. So
are
it
those
ablades the posterior tibial tendon.
Are those plates, I assume I know the answer, are they going in through the same incisional approach? Yep. Again, no syndesmotic fixation here. So what are your thoughts on whether or not, I just fix so many syndesmoses, just, I just default to doing it. But what are your thoughts on not putting syndesmotic fixation across this fracture?
Yeah, and these are ones I stress, and so if when they're oftentimes, there's some people even go in this camp. Well, if you fix the posterior malleolus, the syndesmosis is stable, and I found that's absolutely false, and people should stop saying that because, just stress it after each time you fix it, and you're going to notice some instability at some point because, that's been debunked, and so. This is just one particular one where we got restoration and we retethered the PITFL, and actually it regained stability. I suspect there was no AITFL injury in this one. I think the ones that I found, if there's any residual instability, it's either the PITFL insertion was not realigned. It's always based on the fractured anatomy of the posterior malleolus, or the AITFLs involved as well. And so that's why I always stress it, because just because you fix the posterior malleolus doesn't necessarily mean syndesmotic reduction. Fortunately, this patient didn't have a syndesmotic, or they did, but it got restored with the posterior malleolar fixation.
Well, yeah, you hit on it there. I think the true statement is, if you fix the posterior malleolus, you may not need to fix the syndesmosis, right? It may render it so that you don't have to fix the syndesmosis. It doesn't necessarily mean that you won't have to do it. So I'm a big proponent of stressing. Fix this, stress it. Fix that, stress it. And I think you are too. And I think most people are. I'm not saying anything groundbreaking there, but that's such an important concept to figure out, okay, is this stable? Because there's so many structures that collaterally stabilize something, meaning that, you know, you can have one component of it that's stable and one component of it that's unstable. And if you fix this, well, maybe it's stable now and maybe it's still unstable depending on what other structures are broken or torn. So constantly stressing is important throughout the entire case.
And these are 6 months out, just showcasing the, you know, the maintained alignment of the mortise, and, you know, everything looks kind of good and you know, and stable. And she ended up doing very well. And, you know, it's kind of frustrating because it's going to be difficult for me to do any long-term research on these patients, because I would love to, but they just never show up after like 6 months. You know, it's like they're doing so well, and despite you saying, I would love to see you in a year, they never show up.
Right. Exactly.
You know, unless there's a problem.
Yeah. I usually tell them, hey, I want to bring you in. We'll get an X-ray. I won't charge you. You won't pay anything for the visit. I just want to see what's happening. And even then, still, they don't tend to show up. I get it. They're busy. They got other stuff going on. But you know, the people who aren't doing well, they won't leave you alone. They'll come every day. They'll show up every day. The people who are doing great. I always joke with my wife, because you get home at the end of the day, like, I don't know. My residency director always said, I don't know. I don't think I helped anyone today, because it's a self-selecting population of all the people who are happy are gone. They're off in the world living their life. They don't come back anymore, and they don't come by they don't stick their head in and go, hey, doc, remember you fixed my ankle fracture 3 years ago? It's doing great. Wanted to say, hey, keep up the great work. They don't come by to say that, right? They're off living their great life out in the real world. It's all the other people who keep coming back like, oh, I don't know, it still hurts. Like, oh my gosh, I'm not helping anybody. But yeah, if you could get these people who are doing well to circle back every now and then, it would also make you feel better. Not only could you check your work, but it also kind of stroke your ego a little bit and be like, okay, good. I guess I am helping people here.
Yeah, I don't think it's too much to ask just to stop by, you know, and just say, hey.
Yeah. I put you were a broken bag of potato chips. I put you back together almost perfectly. All right, let's jump to this final case here.
Yeah, so from most simple to most, I guess, involved. Here we have, you know, AP lateral of what appears to be a kind of a distal tibia interarticular pilon type variant injury. This is a pilon. This isn't even a variant. This is a kind of a type B interarticular component that's relatively in good position. But you know, the thing is with these is that, you know, there's a posterior malleolar component of this too, just because of the posterior displacement of the talus relative to the tibia too. So this is one where, okay, I don't play around with these. You know, this is more higher velocity. This patient's soft tissue envelope was just horrendously edematous, and so these are ones where I always do spanning X-fix on these just to allow things to calm down.
So tell the younger people what you're actually doing. You're putting on a delta frame?
Yeah, yep, just a standard delta frame, just 2 tibial half pins and a transcalc pin, and then just pulling it out to length.
How long are you leaving that on?
Usually 2 weeks, and week 3 I'm bringing them to the OR. That's pretty typical for me, I found.
Are you having people do pin care, or are you leaving it alone? Are you letting them bathe? What are you doing?
So I actually use X-fix sponges that are kind of either have silver or betadine and I just leave them in place. I
Yeah.
tell them, don't even look at it, don't touch it, don't even think about touching or looking at it. And I just guess I just have like, because sometimes these patients are in like nursing facilities or
Yeah.
and
Sure.
they don't know what they're doing. And I've had more issues with pin breakage or back out or drainage when they start messing with it.
Yeah. Yeah, I like those little, I don't know if it's a company or something, but I've used those little sponges that just kind of go over it, and they get these little clamps on it, and you just leave them alone. Just don't touch them. Don't, like you said, don't even forget this happened. Just
Yeah, exactly.
don't even look at it.
Don't mind
All right,
these
so,
2 pins sticking out your tibia.
yeah, it's hard not to look at that. So what are your initial treatment thoughts? Obviously, we're going to get a CT scan on something like this, get some more information, but walk us through your thought process. Let's say that we just got these images from the ER doc, and then what's your next step? You said that you put them in a Delta frame, but let's go back. Did you order a CT scan?
Yeah, so I never get the CT scan, pre-reduction, just because, it's not going to give you the best, I guess, three-dimensional roadmap of the fracture anatomy. So I always get post-distraction CT scans right when they leave the PACI.
Okay, interesting. So you're putting the Delta frame on and then getting the CT scan. And your thought process is that now we can see the post-reduction alignment versus the, convoluted mess of things that's going on before I start to put it in more stable alignment.
Yeah, and I just like making things easy on me too, and I think by getting it out and getting out to length, and it gives you a much better idea of what you're dealing with.
Sure.
Yeah.
So we got the CT scan here. Tell the people what we're looking at.
So yeah, we have this, we have the frontal or coronal CT scan on the left. We have a vertical shear medial malleolus with an anterolateral fragment.
Yeah.
And then on the sagittal rendering, we have a nice little, we got a 2-part almost posterior malleolus with a central, coronal split with a mildly spaced posterior mal. And then you also have this, it's likely a portion of that anterolateral component as well on the sagittal.
What you have here is a mess.
Yeah, it's definitely not, it's suboptimal for sure. I think the biggest thing too, at least for young viewers watching this too, something that was drilled into my head by a traumatologist in my residency was, when you're putting these Delta frames on, you got to plan for your second stage, making sure those happens are away from the area of fixation and so I try to make those as proximal as I can to ensure there's no interference with future fixation, because these anterolateral plates, which typically are common with these pilons, they can be pretty long, and so you want to avoid any sort of interference.
Yeah. So what are your initial thoughts on fixation options for something that has so much comminution? Are you leaning plates? Are you pinning the hell out of it and putting screws in? I'm sure we'll see the post-ops here, but I just want to get your thought process behind what you're thinking about when you start planning.
Yeah, I mean, definitely my intraoperative images, it just looks like Hellraiser with all those wires,
All right, we'll jump ahead.
Yeah.
Oh, we don't have. Okay, never mind. Keep going.
I don't think I don't think I added those, and because oftentimes the radiology tech never saves them.
Yeah.
But yeah, it's definitely just getting kind of working systematically, kind of going Volkmann or posterior, working kind of anterolateral, kind of like almost clockwise, addressing the anterolateral component and then addressing the medial component. Sometimes it's easy to start posterior first, just because you can detach the anterolateral component and access the posterior, especially if there's any central paction, which fortunately there's a little bit here, so you can just get a Freer, disimpact that pretty easily through the central, and then working away and provisionally fixing it and doing it that way.
Yeah. So, stepwise approach, just kind of pin this, pin that, pin the other thing, and then try to put it all back together. Once you've pinned it, are you trying to use the plate over the pins, or how are you converting pinning to plating?
Yeah. So I put in so many pins because I know I'm going to take multiple out. And I'll try to angulate them from, kind of in a way, in a manner where I can position the plate without as least interference as possible.
Okay.
And so, and also there are times too where I am doing these subchondral screws outside the plate too. In this case, I didn't have to do that because I was able to position the plate very nicely. But you can put screws outside the plate to stabilize the subchondral component and get stability that way. And then there's also components if there's any cortical deficit, you can actually do like these mini frag planes and use them as cortical replacements, and that's going to give you stability as well. But this is a relatively, from a pilon standpoint, relatively straightforward in regards to the overall alignment and extent of comminution. There actually wasn't a lot of comminution, or if there was, it was all in relatively good alignment. So
Sure.
it was relatively straightforward from that standpoint.
So what was your incisional approach? Is this prone or supine? Obviously,
This was supine. This was
because
supine.
the plate is
Yeah.
anterior. Where is your incisional approach on this?
So this was actually a 3 incisional approach, right? An anterolateral, and then I did a straight medial, and then I did a very, very small lateral incision, which I think is another application for kind of combining open and minimally invasive these last couple of cases. I don't think I would do I necessarily probably wouldn't do a plate at the same time where I'm doing an anterolateral approach. If I ever, I think before with this approach or type of pilon, if I wasn't introduced to intramedullary fixation, I'd probably consider plating first while doing the frame, getting the length alignment rotation right, because that can help with your distal tibial pilon alignment.
Yeah.
But in this case, you could do a nail at the first stage, or you could do it at the second stage. I'd have felt like I didn't have to do the nail at the first stage just because after the reduction, I'm like, gee, this thing's pretty much perfectly aligned anyways. I'll just kind of wait to do it at the second stage, and that's what I did. You could do either or. I think in this case you wouldn't be wrong either or.
Sure.
So, but yeah, this is a 3 incisional approach.
I think these are very difficult fractures on the surface, but with the correct techniques and obviously anatomic hardware makes life easy because you can kind of fit it. Sometimes it makes it harder though. Sometimes I use the anatomic hardware and I try to put it on something and I'm like,
oh yeah,
whoever they molded this plate for is not this patient. Like, I don't know where the disconnect is, but like that plate doesn't fit on this patient, and that's frustrating. But when the anatomic variant plate fits the anatomy of your patient,
yeah,
it does make things easier. It just doesn't always go that direction.
that's super.
Yeah, when you understand the principles of fixation, which I think takes a lot of time. This is high level stuff. This is very, very advanced reconstructive techniques. This is far beyond bunions, hammer toes, triples, things like that. Not saying those things aren't difficult and can't be difficult, because they can and are. I would take this over a bunion any day, but that's just me. Understanding the stepwise approach of how to approach these fractures, how to diagnose the fractures, understanding what's happening when you look at a CT scan, and understanding how the CT scan correlates with what you're going to find intraoperatively. A lot of that just comes with experience and understanding. That's probably why your fellowship was so helpful to you from that standpoint. When you see as many different variety of fractures as you see, there aren't many that probably come in the door anymore that surprise you or shock you, or where you think, uh-oh, how am I going to fix that? Just because you've seen so many different variants. But what are your overall thoughts on ankle fractures that get this complex? It's not for everybody. That just, everybody that graduates residency should not be tackling this type of stuff from the get-go. What are your thoughts on who should be doing this stuff and how long it takes to get comfortable with it?
Yeah, I mean, that's a fantastic question. I think, I think when it comes to these type of, injuries, these Pelon or these Pelon variants. I mean, I know me personally. I mean, these are the cases where I was probably scrubbing in with ortho in residency. I wasn't doing a whole lot other than retracting, and so that's, I think, for me in fellowship, I was the primary surgeon doing these ones, and I got a lot more exposure. I felt a lot more comfortable with these higher level type ankle fractures. And so I think in residency, I probably would be way more hesitant to do these if I didn't do a fellowship, just because these are the ones where if it was my attending or whoever it was, they're the ones doing the majority of these particular cases, because reduction is absolutely critical. And these are just different beasts, to be honest with you. So I think at least the fellowship helped me regain a lot more confidence to deal with these head on versus just transferring them to someone who can do it.
Yeah, absolutely. Well, I want to thank you for taking time out of your very busy schedule to join me tonight on this episode. So let's talk up your residency a little bit. Let's help out my buddy, Dr. Schinnebarger up there in Portland. So talk about your residency a little bit and what's going on out there in Portland.
Yeah, well, Portland, it's changed since I've graduated, with who, the whole city. I'll tell you one thing. Portland in and of itself is a beautiful, beautiful city. There's a lot of surrounding areas, Mount Hood, you got, Bend, you got the Cannon Beach, the coast. Some of the best golf, I think, is underrated. And if you're a big wine person, they have the Willamette Valley, some of the best Pinot Noir in the world. I might be a little biased, but that's just a little side note from the ultimate training you get. I mean, you have excellent attendings, you have a phenomenal residency director, you have attendings like Dr. Schinnebarger, Dr. Chomsek. I mean, these people are kind of well respected in the field, and these are people you're learning from for 3 straight years, and it's just fun, and it's just so broad. You see everything, and it's very hands-on. I know there are some colleagues who were in residencies where they were logging, and they were like second assist or third assist and counting those. Everything that we logged we were doing it. And so it was more, I think, a direct, I guess a direct representation of the program of itself and the people we're working with. So I can't say, anything bad about Portland, or the people who I was able to train with up there.
Yeah, I'm a big fan. I've always thought very highly of the legacy Portland program. So for anyone that doesn't know, Drew was a 3rd year when I was a 1st year at UPMC. So we go way, way back, and he was one of your attendings and helped train you out there. So highly recommended. Anyone interested, check out that Portland legacy program. And Jordan, thank you so much for joining me tonight.
Absolutely. Thank you for having me. I had a blast.
Yeah, absolutely. We'll keep after it. We'll keep up the good fight on LinkedIn together. How's that
for
sound?
Sure. Yeah, we'll team up.
All right, sounds good. We'll take down the bullies together.
Right.
All right, I'll see you over there on LinkedIn.
Sounds good. Have a good night.
All right. Thank you, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.